All right. Hi, my name is Desiree Smith, Masters of Public Health. I work for the National Coalition of STD Directors as the Manager of Health Equity, and I'm very happy to introduce Dr. Oni Blackstock, MD, MHS. She is the Assistant Commissioner of the Bureau of HIV for the New York City Health Department.
Thanks so much for having me.
Thank you. So just to get some logistical things out of the way, the interview is being recorded and these materials will be placed on our National Coalition of STD Directors website.
Mm-hmm.
So for our interview, our first question is, of course, who or what inspired you to start your career as a primary care and HIV physician?
Great. So just going way back to my childhood, so I was deeply inspired by my mother, Dale Blackstock, who was a kidney doctor, and she practiced in central Brooklyn for most of her career. My mom is originally from Brooklyn and has not a completely unique story, but really had a lot of determination and fortitude. She was born to a single mom. She was raised along with her 6 siblings by her mom, and raised on welfare, and was really able to beat the odds and go to college. Then she went to medical school, and then she came back to Brooklyn to practice. And I just saw the extent to which my mom derived a lot of joy and fulfillment from her work. She also was involved in a lot of community health work. And I also saw the way in which community service and advocacy intersected with medicine and being a healthcare provider. And so that really motivated me to want to go to medical school. And then in terms of choosing primary care, internal medicine, and HIV here, in terms of primary care, which means I provide medical care to people who are adults, and general medical care, so people who have a cold to all the way to having congestive heart failure or high blood pressure. And I was really interested in that because I love the sort of the range of clinical conditions that my patients had, and patients could have usually more than one. And I also enjoyed the way that I could really get to know my patients and understand, how the social context in which they lived influenced, their decisions about their health and their health choices. And then I got really interested in doing HIV work because as a medical student, I traveled to Ghana, which is in West Africa, and South Africa to do HIV-related research, and then came back as a medical student still and saw a number of the similar issues that I saw in Sub-Saharan Africa sort of existing here, and so stigma around, when it comes to HIV, around sexuality, see those who are most marginalized being most vulnerable to HIV, and just saw a lot of parallels and really wanted to continue to do work around HIV here in the United States. And so I ended up doing a primary care internal medicine residency and then followed by an HIV fellowship.
Awesome. So to continue talking about your experience, our next question is, you consistently advocate for women to be included in PrEP and the federal plan to end the HIV epidemic. What are your goals and period aspirations for including both transgender and cisgender women in the end of the HIV epidemic?
Great. So I think, historically when we think about the HIV epidemic in the United States, and even globally, but particularly in the United States, the voices of women haven't always been centered. And so for a long time, HIV was really considered something that in fact affected men primarily. And while it still does, we do know that the women, both cisgender and transgender women who are impacted by HIV, are typically women from the most marginalized of groups, so women who may be Black or Latina, women who may be involved in sex work, women who may use substances, and so we know that that women who are really the most vulnerable to HIV really should be the focus of all of our efforts. really focused on women. And just even at the beginning of the epidemic, there was this whole thing about, like, people would say women don't get AIDS, and that some of it was related to the fact that some of the AIDS-defining illnesses, the cervical cancer, for instance, that wasn't actually listed in the criteria for AIDS. And so what ended up happening is women could not necessarily benefit from the extra care and extra benefits that came with having an AIDS diagnosis. And so we see, these inequities really starting off from the very beginning of the epidemic and still continuing now. We see primarily Black and Latina, cis and trans women impacted, mainly women living in high poverty, very high poverty areas. And then even globally, I know we're talking about ending the epidemic here in the United States, but globally, women account for more than half of new HIV infections, and it's almost more than 75% of new HIV infections among adolescents. So, we cannot end the epidemic in the United States or globally if women aren't part of the effort.
Thank you for your response. To follow up with that, we also want to talk about STDs and some of the surveillance data that we have now and its applications with race. So considering some of those stats, such as in 2018, primary and secondary syphilis was, 4.7 times greater for Black females compared to white females, and then 4.8 times greater for Black males compared to white males, and then similar situation for gonorrhea and chlamydia. When considering that data by race and the disproportionate burden of STDs on Black people living in America, how do you think that racism causes those inequities?
Right. So one researcher who has really done a lot of really wonderful, important work in this area is Dr. Adamora Adeora out of UNC. And what her research has really found is how, so for instance, the ways in which, for instance, racism, sexual racism, for instance, leads to poor access to care. It leads to, in thinking about mass incarceration, when we have really large numbers of Black men that are taken out of the population and incarcerated, that leaves fewer options in terms of partners for women who choose to have male partners. And we know that, unemployment rates, lots of things affect these dynamics. And what happens is that HIV and STIs then get concentrated in really the most sort of impoverished areas in terms of, resources and access to care and the like. So what ends up happening when you have a concentration of HIV and STIs, and you have, for instance, for a woman may not have many options on who her partner is, what can happen is you have, for instance, concurrency. So instead of having multiple serial relationships, a woman, because it may be hard to find a male partner, may be more willing to have a partner who has other partners at the same time. That's called concurrency. And so HIV or any sexually transmitted infection, for that matter, can then propagate much more quickly than were people to be in monogamous, exclusive relationships that happened serially as opposed to in parallel. So there are these sort of really large, sort of looming isms like racism and sexism that then affect policies that really then affect the way that people interact and relate to each other, when it comes to sexual networks. So, for instance, if a woman, a Black woman, for instance, even if she has one partner, if the prevalence of STIs or HIV is high within her sexual network, there's really not a lot of room for error. So, if she has one partner and she thinks with this one partner, you only have one partner, I shouldn't have to use, I'm assuming I'm the only partner, I shouldn't have to use condoms, but that could place the woman at increased risk, even though she's engaging in what she thinks is self-protective behavior by having one partner. So I think, lots of these issues around, whether people can get, tested and treated for HIV and STI, so having good access to care, whether people, women in particular, feel empowered in their relationships to have their partners wear condoms, that plays a role. And then obviously, as I was saying, these larger policies that take a lot of Black men out of the population and then, create situations where the risk of HIV is much higher. and STIs. HIV is an STI.
Yes, we are definitely agreed on that here at NCSC, that HIV is definitely an STI and also puts people more at risk for STDs. Following that, our next question is, what interventions or programming does health equity and the dismantlement of racism mean to you? So what exact things that you could say directly to your field that we, or anyone else really that wants to get involved in this work, that we could do to achieve both health equity and the dismantlement of racism in order to close down these disparities?
Right. So I think a lot of sort of previous writings on in research around HIV and STIs have focused a lot on individual level behaviors. So the number of partners someone has, or if someone is engaging in sex without a condom or not using PrEP. And I think, that's, information that needs to be considered, but I think we need to also look at sort of larger, a social context and the ways in which, for instance, racism or sexism may impact people's ability to be able to keep themselves healthy. So, for instance, there's PrEP, which we know is a really effective tool in preventing HIV infections. But if someone, and we know disproportionately, for instance, Black people have lower rates of insurance, of health insurance, and that's, we can link that back to many different policies. But as a result, for instance, in the South, for instance, Medicaid was not expanded. So we have, the South as a new epicenter for the HIV epidemic, and the fact that we have, there's a very low rates of insurance. And so that impacts people's ability to then get PrEP, for instance, to be able to stay healthy and stay HIV negative. And so it would be really about, ensuring, for instance, that we expand Medicaid, that people, because these are large policy changes that can really help to eliminate existing inequities. And so I think we have to do things like expanding Medicaid. And I think when we're doing our programming, as a public health department, ensuring that we are considering how issues differentially affect people. So we know, for instance, medical mistrust is an issue, and so people, Black people in particular, may be less willing to come in when they're having a problem, a medical issue. And so, how can we ensure that, for instance, the programs that we support are staffing folks who look reflective of the communities that are impacted, and that also have a really culturally sort of responsive care that they are providing. So I think all of those things are really important. I think we're also here at the health department thinking about when we are also giving out funds, bidding out the funds, federal funds and local funds that we receive to help support organizations in providing HIV prevention and treatment services, that we also want to make sure that we are reaching, grassroots organizations that are in the communities that are most impacted and that are uniquely positioned to, engage folks who are most vulnerable to HIV. So these are I think there are lots of different ways that we can really work to reduce existing inequities that we see in terms of STIs as well as HIV. But just to say that it's a process, right? Because racism has existed for hundreds of years. And so we can't expect to see things turn around in a very short period of time. And so we are really, really invested in the process of figuring out how we can ensure that care is provided in a way that is equitable.
So to quickly summarize, what you're saying is that a commitment to the ongoing process of health equity and dismantle racism would need to start looking at our policies and how we cause health disparities, and also our programming and making sure that our programming is reflective of our patients and their needs, and that they can come into environments and be, treated holistically, top to bottom, and build a relationship of trust with their healthcare providers.
Exactly. Yeah, I think there are probably many different ways to address this, but I think those are a few different approaches.
Thank you. Did you have any questions for the National Coalition of STD Directors or myself, or just any other comments that you'd like to make to our members and anyone that's viewed this?
Oh, sure. I mean, I think, well, just in terms of statements, just, we work very closely, here in New York City at the health department. We have a separate bureau of HIV and then a separate bureau of sexually transmitted infections, but a lot of the work we do is very integrated. So at our city-funded sexual health clinics, folks, can get tested for non-HIV STIs in addition to HIV, and they can also get same-day PrEP as well as same-day PEP and immediate HIV treatment. So we have really worked to integrate in many different ways, not just in our sexual health clinics, but in the organizations that we fund to ensure that there's integration of HIV and STI testing testing and treatment, because we know that they're very linked, and we cannot end the HIV epidemic if we don't also address STIs, and we can't address the rising rate of STIs if we don't also address HIV. So that's one thing to say, and I think that's probably it for now.
Thank you. I really appreciate you tying the really important relationship between STI and HIV. I think that's something that our field together in public health is really putting a lot of effort to make sure that we address, and that, of course, the way the End the HIV Epidemic Plan is being put out and programming is going, that we really consider that relationship to make sure that we do end the epidemic here in the U.S. I would like to, again, thank you so much for taking the time to interview with us. And if you have any further questions, of course, you can follow up with me. And if anyone else who's watching this interview, you can also email me at dSmith@ncscdc.org. And again, thank you so much.
Thank you so much, Desiree. It was a pleasure speaking with you.
You too.